everyone, and happy International Clinical Trials Day. Thank you so much for joining us today to celebrate the special day and also this often invisible workforce. Today's moderator will be Dr. Houssem Eddine Ben-Ahmed, so I'll be passing over to Houssem. Just a quick introduction. Houssem is a senior research associate at the University of Ottawa and Canadian Health Workforce Network. He is also our very dear co-lead for the Mobility, Migration, and Integration. Over to you, Houssem.
Thank you so much, Raha, and welcome everyone. So thank you again for joining us in this webinar that is hosted by the Canadian Health Workforce Network. And in this webinar, we're going to explore the workforce behind clinical research excellence. So just a brief description of this webinar. So we're going to focus on the clinical trials, which are the cornerstone of an innovative, high-performing healthcare system, enabling early access to new therapies, generating real-world evidence, and driving continuous improvement in patient care. So at the central of this ecosystem is the research delivery workforce, the professionals who make clinical trials possible. So in this session, we'll include a presentation that will outline the key elements of a national strategy for the clinical research workforce, because through strengthening this workforce is essential to enhancing Canada's clinical research capacity, building a resilient talent pipeline, and maintaining global leadership in clinical research and health innovation. So the presentation will be followed by a facilitated discussion with sector leaders and interest holders to explore practical pathways for workforce integration and system-level change. So this is an important conversation, particularly in the context of an important workforce shortage in Canada and beyond. So we are fortunate to have with us an exceptional speaker who will share her expertise and insights. Munaza Jamil, which she brings 25 years of leadership experience in clinical trial operations. She teaches in McMaster University Applied Clinical Research Program and serves as a National Director for Canada Clinical Research Workforce Strategy, working with academic institutions, healthcare organizations, and industry partners to strengthen nurse research capacity and the talent pipeline supporting clinical trials. Her work advances the recognition of clinical research professionals and strengthens workforce capacity across Canada's research ecosystem. So before we begin, I would like to go over a few housekeeping items. So the session, as you see, is being recorded. So please feel free to submit your questions through the chat or Q&A box throughout this session. So you can submit your questions in English, French, or in Arabic. And we will reserve the time at the end to reply to your questions. So we hope today's webinar will be informative. Thank you again for being here today. And without further ado, it's my pleasure to welcome our guest speaker to present her webinar.
Thank you so much, Houssem, for a wonderful welcome and such a warm welcome. Thank you so much, everybody, for taking the time to be here today and to hear this presentation, and really looking forward to learning together during this time. So the name of the presentation, of course, is to talk about Canada's clinical research workforce strategy. And when we talk about the workforce strategy, as Houssem mentioned, what we're talking about essentially are the folks who run clinical trials. So the clinical research professionals, they're called, and the acronym is CRP. And these are the folks that are project managers, trial managers, quality assurance folks, research ethics officers, and many, many others across the workforce. So those are the folks that we're talking about today. So why is this important? Well, of course, we know clinical trials bring early access to emerging therapies that would otherwise take years to reach us. And they generate evidence for improved standards of care. They advance health equity when trials serve marginalized and underserved populations. They, of course, also support innovation and retention of scientific talent. And last but not least, importantly, they attract investment and enable Canada to also contribute meaningfully to global research. So when Canada's clinical trials capacity, the ability to run clinical trials across the ecosystem declines in any way, Canadians then are the ones that it's the public at the end who suffers those consequences. They lose access to cutting edge treatments, or there's delays in getting those treatments to them. And the country also loses both scientific leadership and economic opportunity. So building the workforce is a direct investment in better health outcomes, in health system change, and timely access to building to life-changing therapies. Clinical trials then cannot exist without a specialized, well-trained workforce. And so the quality, the speed, the integrity of every single research project depends on the people who design, coordinate, monitor, and manage them. And right now, the clinical trials ecosystem is kind of reaching a crisis point. There's challenges on many fronts. They're constrained by workforce shortages. There's a high turnover rate and a lack of recognized sort of qualifications, if you will, or standardized competencies. So when the workforce is unstable or inadequately trained and not appropriately matched to the job that they're hired for, trials will suffer the efficiencies, the operational burden, they slow down, protocols have more violations, the quality is going to suffer, and ultimately sponsors and funders are going to take their studies elsewhere. So I alluded to this a second ago. What are the problems then? What are those challenges that we're facing on different fronts? Well, there's a shortage of qualified and trained CRPs. And when I say shortage, I don't mean that there's not enough people who are willing to perform these roles. What I mean to say is that there's not enough people who are adequately trained or trained in a nationally sort of harmonized, standardized way. There's no national framework for training and qualifications of CRPs right now. And that's something that we need to, of course, work on if we want to elevate the profession. There's also a lot of inconsistency around hiring practices, and there are some structural sort of barriers that often exclude some specific cohorts of individuals. And for those of you who are on the call who might have been searching for a job or might be planning to search for a job in this field will know this all too well. And we'll talk about that in a second as well. Like I mentioned, also, there's a lack of alignment and mutual understanding across the country on job titles. They're matching sort of role descriptions. What are the minimum expectations and qualifications that are required to perform those roles? Also, in the academic healthcare side, there's a reliance on start-stop sort of staffing models. So basically, clinical research professionals will be hired when there is a project that comes with its own funding. They'll be hired for that work, and then when the funding ends or the project ends, they're let go. And then the cycle starts over and over and over and over. So there's this constant turnover of staffing that's happening at the clinical trial site. And the site is exactly that physical position where you need the most stability, because that is where patients and discovery are interacting. And then, of course, because of this temporary staffing model, there is a reduced quality and limited continuity in the trials that are in the pipeline. Ultimately, we've also seen, and this has been the culture over decades now here in Canada, that because of this sort of gig economy, this sort of temporary staffing model, a lot of seasoned talent who start off at the academic healthcare side then leave academia for more stable and secure private industry roles, because that's where they find the recognition, that's where they find the stability. And so that, once again, leaves the trial in a position where they have constraints around staffing. So where do we stand in the global sort of realm of it? So Canada is in a strong position, a very strong leadership position, but we need to recognize that in today's day and age, leadership is not static. It's very dynamic. So you have to work hard to kind of maintain that, that position. We know that other G7 countries, such as the UK, USA and Australia, have already recognized the need to have a nationally coordinated talent strategy around the delivery workforce, and they have different initiatives that they have already either worked on or have started to invest in to build capacity and capability in the research delivery workforce. And so we know, of course, that countries that have this coordinated talent strategy are going to be better positioned to attract more opportunities because they can show that they're thinking about timelines and strong talent pipelines. And so when sponsors and funders come to Canada, they, of course, do assess academic excellence, but they also look at the operational side and the how is the trial going to be delivered? How is the project going to be delivered? Is it going to be on time? Is it going to be on budget? And is it going to be with quality? So what is it that we would like to do? A few things. So the first piece is that we would really like to develop some very structured, transparent, clear entry pathways into the profession. So how do you become qualified to become a CRP, as well as advancement pathways so that professionals know how to kind of map their own career trajectories once they're in the profession. We also want to develop a competency-based framework for CRPs, so that all of those job titles that I was talking about, they can be filtered down by function and then mapped to competencies that you require for those roles. And then along with job descriptions and qualifications as well. We also want to advocate for more equitable hiring practices and employment practices, more stable staffing models and compensation equity across the country. We are also right now having some conversations with our colleagues in the federal government to advocate for an occupation classification to be assigned to clinical research so that there's more visibility for it as a profession. So there is opportunity for Canada to grow and to become a global leader in this space, but it's only if we decide to professionalize and grow and sustain the workforce. Another piece or aspect of this work, which is really important, very personal to myself, is that when we have a diverse workforce, it will also ensure that trials are going to be inclusive, accessible, and representative. So one of the pieces that we're really looking to strengthen through this strategy is that when we build a mobile, capable workforce, so a workforce that is recognized for national standards and national training and qualification standards. What that means is that a research coordinator or a project manager who is working in Toronto is able to move across jurisdictions, across provinces, if they want to, and still be recognized for the unique expertise that they bring and still be paid in an equitable manner. So they're not going to be paid equally, but just like any other allied health professional or regulated professional is understood, it's recognized that this is who they are. If they're a nurse or if they're a physiotherapist, etc., across provinces, a clinical research professional would hopefully be recognized in the same way. And what that will do is also help us to bridge that gap between populations who are either having limited English proficiency or they are historically underrepresented in clinical trials, and also those who geographically might feel disadvantaged because they're not having access to the research that is being done in most urban centers. A lot of very recently, I've heard a lot of conversation and very important conversation on how community hospitals, rural and remote sites are wanting to build research portfolios so that they can serve their local populations better. And that's wonderful. But a very vital piece of that is to also build intentionally the human infrastructure that is going to be needed to support that research program. And that is what we would really like to focus on. Another piece is that anecdotally, and we're hoping to measure this soon, about 80 or even higher percentage of the workforce that makes up clinical research professionals, these roles are held by women. And when we talk about job instability, limited advancement pathways, all of those structural barriers that I talked about in terms of entry into the profession, advancement into the profession, the gig economy sort of staffing model and inequity in compensation practices, that all of these things just sort of come together to create even more barriers for women that they than what they would normally have to face anyway in their careers, right? And then the other piece is that we have a large cohort of individuals who are newcomers to Canada. They might have been medically or scientifically trained from foreign programs, but they're foreign foreign obtained credentials and competencies are not being recognized here in Canada. And so what we would really like to do is to create a credential recognition program or a pathway that enables individuals who want to enter into the research sector here in Canada to sort of more efficiently transition. And so what are those requirements that they need, right? So we want to talk about all of that through the framework that we'd like to create. And then last but not least, we know that Indigenous students who are right now enrolled in life sciences programs across the country are rarely exposed to clinical research careers as an option. And so we really like to build that partnership with life sciences programs who have a high enrollment of Indigenous students to kind of expose them to this as a career option should they wish to follow it. And that would enable us to not only build diversity in our workforce, but also build those partnerships and bridge those trust gaps with Indigenous communities in the research space. So, we talked a little bit about why this workforce is often hidden and we call it invisible. So clinical research professionals work in the same hospitals and clinics as other allied healthcare professionals, doctors, nurses, physiotherapists, pharmacists. They're working right alongside. But while they are physically positioned there, they're often invisible when it comes to conversations around operational budgets or capacity planning, etc., because their funding source is different. So they fall outside of the operational budget for the healthcare institution usually. And so really we also want to think about how do we move beyond that and how do we frame the conversation as a research integrated healthcare workforce model so that we're not looking at two different systems that are competing for talent. We're actually looking for a more unified system. I already mentioned the internationally educated healthcare professionals that would add a lot of a talent to the pool here, but are not finding it very easy to transition smoothly into stable CRP roles. And last but not least, really just wanting to end about why this piece is really important at a national level. I talked about at the outset that clinical trials generate investment, they create jobs, they strengthen the life sciences sector. So they're really an enabler for economic growth. Of course, also health innovation, patients gain faster access to innovative life-saving therapies. And a lot of these therapies are only available to them through clinical trials. So if we talk about the oncology space or the pediatric space, the rare disease space, some of these clinical trials are the only options that patients have to receive any kind of treatment. Also, it goes without saying when we invest in our workforce and develop skills and try to elevate a mobile skilled workforce, that is going to extend capacity to all communities across Canada. And that sort of democratizes clinical trials for everyone who's living in Canada so that they have access to those opportunities that people who live in major urban centers do. And last but not least, a skilled workforce means that Canada can design and run more clinical trials domestically, and that reduces dependence on international expertise or infrastructure. And that's it. Thank you so much.
Thank you so much, Munaza, for this wonderful presentation, especially the last slide when you said like why this is matter, and we can see like the contributions of that to the economic growth and everything. So sometimes, people that don't understand the link between workforce, between the healthcare services, etc., they feel that it's disconnected, but there is a real link between both of them, and how the workforce is the backbone of any transformative healthcare system.
Yeah.
So for the attendees, don't hesitate to ask questions if you have any questions for this. I know, like today, like I'm in France. My cousin told me, let's go for a tour for Tour Eiffel. I told her I cannot. Today I have an important presentation, like webinar, and I would like to assist because this speaks very well to not only to my expertise, but also for those who attend and for those who would like to have access to innovative therapies and everything. So they need to understand that the workforce is very important to reach and to arrive to that high quality services. I have just one question I would like, if it's possible. So you spoke about the clinical research workforce as an invisible workforce. So my question is, like, why do you think this workforce has historically been left out of broader health workforce planning or conversations? And what are the implications of that?
Yeah, absolutely. So, I mean, I think part of the issue is structural, right? So I said that physically, the clinical research workforce is positioned in the healthcare space. So they're literally in the same buildings as the other healthcare professionals who are providing care to patients, and
Mhm.
they're working right alongside them. But because the funding for these roles comes from a separate space, they're often kind of left out or traditionally have fallen outside of those conversations around health workforce planning and operational budgets, etc. But and also the other thing is that CRPs, of course, are not regulated, right? They're not a
Mhm.
regulated profession, but they do have a unique skill set. They do need training. They are specialized actually in their roles, and they have very unique clinical and regulatory duties. And so it's our role then to kind of elevate the importance of the workforce and make it more visible to say, this is the value that these folks bring
Mhm.
to the broader workforce. You asked
Mhm.
about the implication. So the implication is that Canada has built a very important part of its innovation ecosystem, which is the clinical trials enterprise. But they haven't built it, they've built it without building the human infrastructure part of it, which is the research delivery workforce, which is what is needed to sustain it. So, unlike other sectors, as I mentioned, we don't have those standardized career pathways. We don't have harmonized alignment on what training and qualifications are needed for CRPs. There's many, many diverse talent pipelines that kind of feed into the profession. There's not a lot of stability within it, so people come and go, etc. There's not a lot of data either in terms of workforce data around this. And then last but not least, the unstable sort of
Mhm.
inequity in the staffing models and the compensation practices. So then as a result, of course, organizations do face those challenges like high turnover and reduced quality, instability, limited capacity. So the key ultimately is that clinical trials cannot expand sustainably without intentional workforce planning. And if we don't invest in and strengthen the workforce, the research delivery workforce, there will be broader impacts on patient access to trials, on health system innovation, and ultimately Canada's ability to lead in this global space.
Absolutely, that's really very informative answer. And here, just to clarify a little bit, what do you mean by CRP, especially for those who are not familiar with this group of unregulated workforce?
Yeah, absolutely. So CRP is an acronym for Clinical Research Professionals, and these are the folks that are delivering the research. So these are trial monitors, study startup monitors, managers, sorry, project managers, research assistants, research coordinators who are directly working frontline with the patients and their families to enroll folks into trials. These are your trial monitors, quality assurance and compliance folks, research ethics officers, etc.
Wonderful, excellent. Thank you so much. So here, now we have a comment from Osama. It's like advocacy for a national occupation code. has been on the agenda in Canadian clinical research for over a decade. What is the concrete mechanism through which this initiative will accelerate NOC, the classification for CRPs, and what measurable milestones should we expect within 24 months?
Right. Okay. So, oh, go ahead.
Yeah, I think
Go ahead.
also there's another comment. So also given that CRPs are currently funded through research grants rather than operational health budgets, which directly limits job stability and immigration sponsorship pathways, does this strategy include any mechanism that to shift CRP funding models so that sites can sponsor work permits?
Okay. So the first part was the advocacy for the code, right?
Yep.
Now, this is not unprecedented. So in the US, I will say, last year in the spring, ACRP, which is the Association of Clinical Research Professionals, which is a national not-for-profit in this space, had submitted an application to the US Bureau of Labor and Statistics for the first time to advocate for a standard occupation code, is what they call it over there in the US, to be assigned to clinical research as a profession. Where that's gone, I don't know, because I think the government's really busy doing other things right now. In the UK, the NIHR, which is the federal sort of, health research funding body, has taken on this role. And they already have an occupation code that's assigned to clinical research practitioners, they call it in the UK, CRPs. And they have an entire pathway already set up about how you qualify to become a CRP. It's all on their website. Where do you go to qualify? What are the trainings you need to do? Then you come, you get accredited. You have 16 performance standards. There's a defined scope of work, et cetera, et cetera. So they've already gone through this process. Canada, you're right, perhaps has been thinking about this for far too long, but somebody has to kind of take that leadership role. And so we're very happy to have already engaged with colleagues from the labor classifications program, I think it's called, and it's within ESDC, so economic and social development, I think. And we had a really good conversation with them. In Canada, the rule is that you can only apply for a new occupation code every 10 years. So that window of opportunity only opens up every 10 years. The next window is in 2031. The government stops accepting applications roughly 2 years before that. So 2029 would be the time to make your application. Now, when we had the conversation with them, they did say that they feel that our application might be better aligned with the UK model. Rather than the US model, because the UK model is actually only advocating for the frontline clinical research role. So that clinical research practitioner that has that health code attached to them is the frontline study coordinator, what we would call here, or research assistant, et cetera. It's not the ancillary staff that support. And that's okay, and the reason that they say is that it can't be supported, most likely cannot be supported, is because the skills that a project manager has in clinical research, according to them, are quite similar to the skill set that a project manager would need in another sector. And they already have a code for a project manager. So whether you work in this sector or that, if you're a project manager, according to them, you have the same competencies or you need the same skills. So they're only going to allow you to apply for a code that is brand new and unique. No one else can do that, which is exactly the frontline clinical research professional role. So we've started to talk to them. They need some of these outputs that we're working on, the National Competency Framework being like the biggest one. And we've promised that we're going to be in touch with them within 12 months. So hopefully next year we'll move that conversation forward. And then your other question, just very briefly. So the question was about...
Does this strategy include any mechanism to shift CRP funding models to that SITs can sponsor work permits?
Okay, so I don't know about the work permits, but in terms of the staffing models and making employees more stable and permanent, perhaps there's an entire task force that has been created within the strategy, which is composed of workforce leaders from across the ecosystem. So we have big employers like UHN and Ottawa, Children's Hospital Research Institute. We have some directors of HR as well in that task force, and their task is to propose how can we make the funding models and the staffing models more equitable and more stable. So hopefully through those conversations, we are able to advocate for some serious change.
That's very interesting. Thank you so much, Munaza. So there is another question from Ivy. Like, she's curious about how one would go about enumerating the number of CRPs. Some are regulated health professionals like nurses, physicians, but even the regulatory authorities don't capture that they would be working as CRPs. So that's pretty fundamental. What are your thoughts about this one?
Yeah, so this is exactly one of those problems that we're facing at this time. Now, I should say BioTalent Canada, that is also based in Ottawa, did some work. So every few years they release a national report, a labor market report on the bioeconomy, and biohealth is one of the subsectors of the bioeconomy, as we know. And within biohealth, research and development is a subsector, and then within R&D, clinical trials is a very small piece. But they did try, believe it or not, to try to quantify the workforce in this space, and they were not able to. They abandoned the work just because of exactly this problem where the clinical research workforce is fragmented across the ecosystem. They're working in public spaces, they're working in private clinics, in the industry as well. So pharmaceutical companies, big pharmas, life sciences companies, CROs, etc. They're working in doctors' offices, private clinics that are running clinical trials, and they're working in universities and hospitals. So there is a lot of wide sort of space, which is good because that means that's where clinical research is taking place, but it's very hard to quantify. Um, we have a couple of different ways that we're trying to at least start the process. We had a national workforce survey that has been actually running for about a month now, which is focused on the workforce themselves. So we encourage everyone. It takes about 7 minutes. It's actually closing tomorrow. So I was able to put a good plug in here. But it takes about 7 to 10 minutes, and that's I guess, an effort that we're making, an early effort to try to understand who the workforce is. And then we're also trying to work with sort of like the big employers to start with to try to quantify what their staffing looks like and then go from there. It'll take time, but the willingness to engage across the ecosystem is huge. And that's been very, very positive.
Wonderful. That's really interesting. Thank you so much for that. Also, we have another questions also from, I hope I pronounced the name well, Ijioma. So what are practical ways to break into CRP role in Canada currently?
Right. Okay. So this is the problem is that it's very arbitrary. Right now, it's just really very, very arbitrary. You can kind of get into it if you're lucky or not. There's no standard way to do this. And that's a big problem. I'm contacted every day by multiple people who are looking to transition into clinical research. One of the biggest things that you need to have is Canadian experience. And what I recommend and suggest to people is to try to get that in through the volunteer pathway. Even if it's volunteering in a healthcare institution in a non-research space, it will still open doors for you in the career. So unfortunately, not too many practical ways right now. Is just hit or miss. But what we are hoping to do through the Career Pathways Task Force is to really develop those uh, those pipelines. How do we do this? So what are the diverse pipelines right now? We're thinking there's 3 probably major talent pipelines that flow into clinical research. There's the fresh talent, like the early graduates, early career professionals. There's the international cohort, newcomers to Canada, and then there's migration from other allied health professions. So what do those people come with? What are those competencies? How do we recognize them? What additional work do they need to transition and qualify? And then we need to have it validated by the employers so that everything that they're doing is going to be recognized, and then they have a very good chance.
Great. So now, as the lead of the mobility, migration, and integration policy team of the Canadian Health Workforce Network, I would like to focus a little bit on the internationally educated health workers. And we have a question from Obada. How can internationally trained with newcomer professionals transition from academia to industry? So you know that in Canada we have many internationally educated healthcare workers that they really don't work within their field. They are more like underemployed, or their competition are underutilized. So this is an important issue here in Canada and even in other countries. So how can internationally educated trained or newcomer professionals they can transition from academia to industry from your perspective?
So once again, this is the thing. One of the important pieces that we want to build is career advancement pathways. So a career lattice that helps you understand what are those role classifications. So what are those buckets of jobs within clinical research, and how do you move from one to the other? And not just how do you move, but what is recognized from the other side, from the employer side, in terms of what you bring, what value you bring. So once again, right now, unfortunately, it's really arbitrary. It's just where you apply, who needs you at that time, who you sort of click with, and then you get the job.
Great, thank you so much. Um, I have another question also regarding from a health workforce policy perspective. What would it look like to truly integrate the clinical research workforce into broader conversations about healthcare capacity, workforce sustainability, and system resilience?
Right. Okay. So firstly, to recognize the research delivery workforce, it's not peripheral to healthcare. It's part of modern healthcare capacity. And as we've mentioned, clinical trials are how health systems adopt innovation. They generate evidence and provide patients with access to emerging therapies. So the workforce delivering that research is essential infrastructure, right? It's not optional. It's not an add-on. So we need to recognize that first and foremost, that importance. From a policy perspective, integration means moving beyond that fragmented study by study, short-term contract staffing and employment model. And it includes, of course, then developing some sustainable funding models for these folks that support stable employment. Um, it includes creating those career pathways that are very clear that we've been talking about, entry pathways and advancement pathways as well, based on nationally recognized competencies. So it levels the playing field for everyone, and they're recognized and validated as well. That will help the profession become more visible and mobile across jurisdictions, across provinces as well. Collection of data, workforce data. There was a question that Ivy just asked about the data as well. So we know that health workforce data is collected routinely on health professionals, but there's very little data at a national level that we know about clinical research professionals. So we need to work on that. Without that workforce data, it's also very difficult to plan effectively, right, for future capacity needs. There's an equity dimension. We talked about women. We talked about internationally educated healthcare professionals. And finally, I would say that true integration really means interdisciplinary planning, right? So I was saying before that we really want to talk about how a resilient health system is one that can deliver care and generate evidence at the same time. And countries that succeed in sort of creating this model are the ones that are going to really lead in this space. They're going to be better positioned to respond to future health emergencies, health challenges, attract innovation, and of course, ultimately improve patient outcomes for those living in their country.
Absolutely, yes. And I really like that slide on the equity component because, like in Canada, we serve like a multi-diverse population. So we need, to include that and as like the women and also the other visible minority or invisible minority, in the workforce. So
Yeah.
that's really very, very important. Um, Also, I have another question is like whether there is an activity to establish a professional association to capture the CRPs across the numerous sectors as a start, but as an association would also do other things like bring attention to this workforce. What do you think about that?
Yeah, so there is a professional association in
Yeah.
Canada. It's called the Clinical Research Association of Canada, CRAC, and they've been sort of actively established for almost 40 years now. But
Mhm.
they are very, very lean. They're very sort of thinly operational, run by volunteers, just kind of, by the side of their desks, etc. So there's lots of room in this space, and I do believe that for those of you who might know our neighbors to the south, we have two very, very strong professional associations that govern CRPs in the US, ACRP and SOCRA. And for many, many years, Canadian clinical research professionals have actually gone and gotten certified from those professional associations, and they have been to a large degree recognized here in Canada as well by Canadian employers. However, just to speak on the part of certification for 1 second, and then I'll go back to the professional association. In terms of certification, we really have to rethink what value certification through SOCRA and ACRP brings to the Canadian workforce, because the majority of these exams focus on US-based legislation, US-based questions. They don't talk about Health Canada regulations or privacy legislation that exists in Canada, which is very different in the healthcare model is very different in the US versus in Canada. So I'm not sure that it should continue. I think there should be, if needed, a Canadian equivalent, a made in Canada sort of solution for certification, if that's what the ecosystem decides that they need. That's one piece. And then, yes, the professional association. So there is that gap. Ultimately, what we would also like to look at is the ongoing sort of stewardship of the outputs from our work. So who's going to implement it? Who's going to govern it? Who's going to, steward that on an ongoing basis? And these are conversations that, we look forward to having.
Thank you. Thank you so much, Munaza, for this very brilliant and smart answers. So, like we have, I see like the audience are really very engaged. I'm so happy to see that they are here, and then that show that how the presentation is very, very important. So, for those who attended here today, what are the take-home messages? What they can take from this webinar of today, and then when we finish the webinar, they say like we have learned something new today from Munaza. What do you, or what are the take-home messages that they can bring with them today? Because we have
Yeah.
like people that are come from different countries. We have Brazil, Tunisia, Egypt, and Canada, UK. You are there,
Yes.
Munaza. So they would
Yes.
like to learn more
Yes.
about this perspective.
Yeah, absolutely. Well, this is really amazing. I love the international audience. And it's really interesting because both Houssem and I are based in Canada, but we're right now logging in from London, UK, and France, respectively. So it's really quite an international day, and very much aligned with International Clinical Trials Day, which is also today. But in terms of take-home messages, so the first thing is that I think in all of our own networks and with our colleagues, we can do work to bring visibility to the hard work that these folks do every single day, and what their unique role is in the ecosystem and what value they bring, and what would be the scenario if we didn't invest in this workforce. So those are conversations that I'd like for everyone to sort of take leadership on, no matter which space you're living in. The second piece is the second thing is if you want, support the Canadian strategy. And we're hoping that not only in this period of time that, since our launch here in Canada, we've actually been having very good positive conversations with our colleagues from across the world. We've had really good consultations with our neighbors in the US, as well as the UK, Australia, Malaysia, Indonesia, Singapore, the WHO, the EU. to name a few. I hope I'm not missing anybody. And New Zealand as well. And so there is this, I think, global momentum I see in many different countries around the world that have, decided that they do want to build a very strong clinical trials ecosystem, whether it's for, healthcare, to improve their own healthcare innovation, whether to lead in this space globally to become more competitive in the global landscape, etc. But and more, like I said, countries are recognizing that in order to build that life sciences sector and the clinical trials enterprise, they need to invest in the workforce, in the human infrastructure. So if you belong to any space in anywhere in the world where this is something that has become a priority, either on the national level or in your region, I really encourage you to take leadership on the conversation of the human infrastructure. And we would also like to, in Canada, become a part of broader global conversations as well. We would also like to share what we're learning and how we can contribute to other people's work and conversations.
Thank you so much, Munaza. I have just like a few, I know like it's just few, still 11 minutes. I have few comments. So here, like given the identified credential gap for international CRPs, has there been any feasibility work around the bridging postgraduate diploma or course-based master's in clinical research hosted at an academic health center like McMaster that carries Canadian academic standing and creates direct pathway into site-based employment?
Yes, yes. So this is exactly the type of work that we're hoping to start now. I mean, we're only like 6 months old, right? So
Mhm.
we have a long ways to go. We see this as a 3-year initiative. One of the task forces that we are going to start pulling together soon is the Career Pathways Task Force, and they have a twofold mandate. One is to create that entry pathway, and then the other one is the advancement pathway. The entry pathways piece, I intentionally want to bring our colleagues from the education sector alongside colleagues from the government who work on bridging and recognition of credentials, foreign credentials, because they have the expertise in that area, which of course I don't have. And then work with colleagues, who are employers, as well as the workforce themselves. But it's going to be a unique blend of skill set and expertise at this table, because we recognize that there's so many different pieces. And I mean, I'm based at McMaster, and so if McMaster could take on this role, or that would be wonderful for us as well as other places in Canada. So we really want to work collaboratively in this space, and hopefully we do come up with a framework that is very well structured and transparent.
Excellent. Perfect. Thank you so much. Also, another question or comment, like, have there been any conversations with Canada specific to academic teaching, research hospitals as to the importance of this workforce to their institutions?
Yes, so we did meet with Healthcare Can. Healthcare Can right now has, I mean, they heard me, but they have some other priorities, I think, right now that they're already committed to. But they did support it in a positive way. And I think the door is open for future conversations to engage with them and their network as well. Yeah.
Great. And whether the off the side of the desk professional association has met with folks at the ESDC to stress the importance of supporting this workforce and also enumerating it at creating maybe a workforce plan.
No, they have not. They haven't. But the thing is also with the ESDC folks and the occupation code application, you need to have a lot of data to support that application, and we don't have any. We don't even know how many people exist in this workforce. We have some estimates, around 20,000, 25,000 people in Canada that work in the workforce, but we really need to have some more support in our application. We need to show how many people are entering, what are their barriers, how many people are leaving the profession, what does the market look like, for this sector. So there's a lot of information that we need to gather before we can go, which is why we are having these early conversations with them. And I have to say they're very, very friendly, very nice folks. I wasn't sure if I was going to really get their attention, but I did, and I'm very happy about that.
Yeah, we are doing a great job. So also we wonder if there is any worthy conversation to have with recently elected, Prime Minister MP Daniel Martin, who stressed the importance of research and infrastructure. Could be in sick kids or Unity Health Network
Yeah,
or other.
yeah.
Okay.
Yeah. Yeah. So no, not to Danielle Martin because she just got elected just
Okay.
recently. But what I am doing, and have been able to do to some degree, is to really build very close alignment and engagement with the downtown hospitals because these are very large employers of CRP talent. So UHN, Sick Kids, etc. The Sick Kids folks are completely on board. They're actually going to work with us in synergy because they have an internal strategy as well that they're going to feed into. UHN have recently gotten in touch with, and we're very good. We have the director of the research portfolio within HR. She's on our talent task force. So really looking forward to having those conversations with these folks first within the ecosystem and then building up a kind of a case to take to the next level to elevate the conversation.
Wonderful. And also, I think this work will be also moved to Pakistan because Osama will share your work in Pakistan with his network. So he is asking also if you have any professional community so they can join to stay connected and also to share and expand your networking, in this important work.
Yeah, no, thank you so much for the support. And LinkedIn space is really where the strategy is kind of living and breathing on a daily basis. So that's where you get kind of like all the updates and announcements. We have a web page as well. And really looking to build this community. Like you said, if we
Mhm.
have a professional community, so now people are coming
Yes.
together, a lot of people are being interested. Hopefully, we'll be able to create some kind of community of practice as well for people to share and exchange knowledge and ideas. And also, I'm looking for some support for communications, but hopefully, we'll be able to put out a newsletter soon as well to our
Mhm.
members.
Perfect. Thank you so much. And thank you so, Raha, for sharing, the link to that page. And also, we have a maybe last question from Sarah. Are you also collaborating with CanTrain for educational qualifications standardization?
Right. So I actually used to collaborate with CanTrain as well. I've built some
Yeah.
content for them. Um, in terms of leveraging their outputs and what they have created, definitely. One of the pieces for this strategy that's really important for all Canadians to know is that we are not looking to duplicate or recreate anything that has already been done in any space across the different initiatives of the strategy. So what we really want to do is to leverage the work that has been done in any area. We want to work with those partners and colleagues who did the work, and we want to just sort of make it more scalable and adaptable across the country. And we really want to come to a national understanding and national agreement on all of these different pieces of reform. So what
Mhm.
qualifies as CRP? How do you become one? How do you get hired? How do your credentials get recognized, etc.? All of these just need to come, we need to come to a countrywide understanding. And that's really it. So really hoping to bring everyone together for the conversation as the work evolves.
Thank you so much, Munaza Jamil, National Director of Canada Clinical Research Workforce Strategy. That was a wonderful webinar. I like the conversation, and I see like a lot of comments here and questions. Thank you so much for joining us in this webinar. We're going to have other webinars also will be hosted by the Canadian Health Workforce Network. So follow us on our website and also social media. Just tap Canadian Health Workforce Network for more webinars. Thank you so much for all these questions. And I see here there is some a lot of comments, like thank you so much. Excellent webinar. I have some off to us. Okay, perfect. So
Thank
I
you so
think
much, Houssem and Ivy. I know she had to leave, and Raha as well for giving me this opportunity to host this presentation and this topic on your not on your platform. I really, really appreciate it. Thank you so much.
thank you so much, Munaza. Ivy would like to say something as the leader of the Canadian Health Workforce Network.
Yeah, I'm glad that we were able to invite you and to shine light on this as an important workforce, health workforce. And yeah, thank you so much. And I will sign off just to
All right.
to
Okay.
get to another meeting.
All right.
All right.
Thank you,
Cheers.
Ivy.
Thank
Take
Bye-bye.
care.
Bye.
Bye.
Bye-bye. Thank you, all of you. So the floor is yours, Raha, if you want to say something.
Thank you, everyone, for joining us. If you are interested in more events like this, as Houssem was mentioning, please consider visiting our website, becoming a CHWN member, and following us on our socials. Thanks again, Munaza, for a wonderful presentation, Houssem for incredible moderation, and all the questions as well. We really appreciate the participation.
Thank you so
Thank
much.
you, everyone.
All right. Bye.
Have a good day. Bye-bye.
Bye.